people, they again requested me that, sir, last time we were not in line, and can you repeat that previous lecture? So I will not going to repeat all of them, but I am going to just give you a brief concept of the previous season 2 part 1. So temporomandibular joint disorders. You well know the anatomy of the temporomandibular joint. I don't want to recall the anatomy, but straightforward we will go to temporomandibular joint. It is a synovial joint which has a superior part with the temporal bone, that is glenoid fossa, and inferior part with the condyle of the mandible, and in between there is a articular disc. That is as simple as that. Ladies and gentlemen, while we are talking of the temporomandibular joint disorders, we have line of diseases, and these line of diseases, actually it is just a rough ABC in front of you. That is deviation in the form of the condyle, whether this form is in the glenoid fossa, whether it is the top of the temporomandibular condyle head. Then is the in between is the disc, and this disc has a different displacement, and we are going to cover this displacement today, inshallah, in detail. And then this displacement of the condylo-disco complex or disco-condylar complex, this results into hypermobility and high dislocation as well. This hypermobility and dislocation, actually it is why it is called as the discocondylar complex, because the whole system is being displaced in anterior aspect. Then is the inflammatory disorder, that is capsulitis and synovitis. Capsule is that part which engage whole of the joint, while the synovitis is the synovial membrane which is within the joint, and it has a very secretory and defensive mechanism, and if there is any inflammation of this synovial membrane, that is called synovitis. We will discuss it in detail. And then is the retrodiscitis. Retrodiscal ligaments and area is a highly vascular area and is a very good innervative. When there is any inflammation in this area, there is a many complications used to occur, and especially with reference to pain. Then is a full list of degenerative diseases. And lastly, when there the last disease, that is the ankylosis, first it comes with the fibrosis, and later on it converts itself into bony form. Ladies and gentlemen, when we talk of the classification of temporomandibular joint diseases, and you go to the net and you search for the different research paper and different presentation, you will see there are so many classification is being given, right from approximately 211 213 to it is in present age is by the Peterson, that is 2014. We have the different classification, and if we go in detail of all the classification, we are confused what to do. And what is the classification of the temporomandibular joint disorder that we can obey, and that is the main thing, that how to classify. So many people has tried. Some people has tried with reference to the diseases parameter. Some people has classified it according to an anatomical orientation. Some people have even classified with reference to the age parameters. So these all are, some have covered the muscles, some have covered the bones, some have covered the, for the inflammation. Then degenerative diseases like this, they have complicated the things in every classification. So when we sort out these classification, and we come to know that they are generally these classification which are generally universally more accepted. That is Peterson classification, taxonomic classification of temporomandibular disorder, Occasion classification of diagnosing temporomandibular joint disorder, RCD, TMD classification, and Wild staging for internal rearrangement of the TMJ. Now, these classifications are generally present, and we are going to discuss step by step the Peterson classification. It is proposed most recently. We can say that is 6-7 years back. It is approximately the universally accepted and more comprehensive. It has divided the classification into straightforward two: articular disorders and non-articular disorder. Articular orders mean that any problems within the joint structure, it is articular, whether they is inflammatory in nature and whether they are non-inflammatory in nature. Then they have divided it to non-articular disorder mainly with reference to the musculature, and then there is certain diseases like fibromyalgia, myotonic dystrophies. These classification like Patterson's are being taught universally. Then is the taxonomic classification. He has made it simple, but it do not covers many things. It has just gone for the TMJ disorder, masticated muscle disorder, headaches, and associated structure. But he has actually is not involved the degenerative diseases with reference to growth, with reference to tumor, and with reference to ankylosis. Also, he has a limitation of taxonomic classification. Then we have the O'Casson's classification. This was proposed in approximately 1994-95. This has also described the things in detail, and he has added one thing more, that is the growth disorder. And he tried to cover this growth disorder, congenital problems, problems with reference to the trauma, and then there is any tumor development and any degenerated diseases as well. So then RCD is a very simple things, that is the required diagnosis criteria. Required diagnostic criteria or TMD classification. This classification actually is a vague classification, and they have tried to cover it with reference more with reference to pain as compared to then TMJ diseases. Now, when we are talking of the TMJ disorders, yet there is always, like all the bigger diseases, there remain the sign of interrogation, and that is yet there. Ladies and gentlemen, we have just gone for the predisposing factor, triggering factor, and maintaining factor. In the episode 1 of the season 2, I have described these predisposing factor, triggering factor, and maintaining factor in detail. And these all factors I have discussed in my last lecture. Every single parameter I have discussed in detail, like anomaly of occlusal function, ligamentous looseness, parafunction, and psychological anxiety and depression. This I have given you absolute complete detail. Then I have gone for triggering factor and maintaining factor. Today I am not going to repeat all these factors, but just I'll give you the previous few slides that you can recall your previous knowledge. Predisposing factor, that is the increase in the risk of a TMD by the systemic condition, skeletal deformities, and the posture imbalance. Then initiating factor. These are the onset causing factors like acute or chronic trauma. And precipitating factor, they interfere with the healing and they complicate the treatment. That means these precipitating factors, if they are present and you are going to treat the TMD, you are not going to be successful, as these precipitating factors do not let the treatment go ahead with a successful way. That is emotional stresses, anxiety, and sleep disturbance. If you look at this micro trauma on the chin or the extrinsic microtrauma at the angle of the jaw. You may get the blow on the opposite side, diversion of the kinetic energy to the opposite joint, and that will result into severe traumatic abrasion to the articulating disc. And that articulating disc may be ruptured, there may be hematoma, or there may be fracture on the opposite side. And then these type of sports, you see the whole the chin that is on the facing to the floor, and sometimes this type of sport which directly hit to the surface of the chin, and that give bilaterally or unilateral trauma to the temporomandibular joint disc, and sometimes it give concussion to the all the structure which are present above the condyle bony area, like the synovial membrane, like the disc membrane, and especially when we are talking of the glenoid fossa surface as well. These type of macro trauma are also present. You see, this man used to take the breaks. He is from India, and he has been reported that he used to take the breaks. And look at this man on your right side, that he is taking so huge bite of the you see how much wide opening is this? This wide opening may result into trauma to the posterior ligaments. As much as you are going to open your this joint wide, you are going to give the stresses or stretching to the posterior ligaments. Then is the bruxism, which is very annoying one. You see, there's a two things. One, the structure of the tooth is gone, and secondly, the most thing is that you are reducing the vertical height of the joint, and this vertical height indirectly give the pressure to the joint to press the disc. And what happens that when you are going on giving the bruxism, it is going on reducing the vertical height, and you see this whole the cast they are gone. And when you are constantly going on doing this, what happens that the vertical height between these two upper and lower teeth, they become very small, and the condylar area, it is more pressing or more forcefully involving the glenoid area. When sometimes it happens to that you are not grinding or you are not clinching the all the teeth, but you are going for the very specific one. Look at this center incisor. She is just biting on one center incisor, and it is her habit, and this one habit may result into a disorientation in the disc surface, either on the right side, either on the left side. And sometimes like this, these are the parafunctional itching. You are looking at some target, and at your silent mood, you are clenching your jaw, and this clenching directly or indirectly pressing the whole of the structure of the TMJ. Now look at this. When you are facing your palm in an angry mood, or you are facing a bowler which is a very competent bowler and a very fast bowler, and going to knock you out in one blow, at that level your tension and your aggression is so that you are pressing your teeth, and you are pressing in such a way that the masseter muscle is going to overexert it, and that overexerting of the masseter muscle results into clenching, results into over forces applied to the surface of the what you say whole of the glenoid fossa, as well as the disc superior and inferior level as well. All type of malocclusion. Yesterday I was listening to a webinar given by our very respected president of ICD, Dr. How Chan, regarding to the clear liners, and he was discussing the malocclusion. And during his discussion, he has also mentioned that we are going to get the many problem with reference to malocclusion, and that malocclusion is whether it is disturbing TMJ anteriorly, whether it is disturbing middlely, whether it is on the lateral side, whether it's on the medial side, and whether it is on the posterior ligament side. But whatever the classification of the malocclusion may be, it is directly or indirectly involving the temporomandibular joint, and that temporomandibular joint diseases basically are very much present in these patients who are suffering from, especially from the crossbite posterior or anterior crossbite. Ladies and gentlemen, there is one thing, very posture. Posture, you see the temporomandibular joint is right here in this portion. And this is the sternocleidomastoid, and these are the anterior neck muscle, and this is the trapezius muscle which is holding whole of the neck posteriorly. And when the muscles are in this position, you see the trapezius is just holding it very nicely, and the flow of the sternocleidomastoid muscle is here. But when this is front, it is absolutely opposite direction. It is not posterior direction, it is now the anterior posteriorly coming down. And when this whole area, which is, it is attached to the mastoid cells, and the connection of the mastoid with all these musculature results into a big pressure on the temporomandibular joint apparatus. You see, if it is a front, it is like this, but when you go more posterior, you are also giving more pressure on this. And these two muscles, especially I am talking of the temporalis and masseter, they are more involved in this type of posture changing, and this imbalance results into TMD. Ladies and gentlemen, what are the symptoms? Clinking and popping noises at the joint, being unable to open the mouth comfortably, lacking of the jaw when trying to open the mouth, neck pain, shoulder pain, back pain, and headaches, and in irregular bites as well. Swelling of the face around the joint, because he is going to press all the time, sometime on the joint superior level, sometime joint inferior level, sometime on the side of the some on the joint, and then sometime on the masseter muscle, sometime on the temporalis muscle. This results into inflammatory response due to constant pressure. Ringing of the ear and decreased hearing is one of the very important things in TMD. Dizziness and vision problem is also associated with the constant pressure on these areas. Ladies and gentlemen, we will today discuss with the articular disc disorders. Although we are going to cover all the parameters of temporomandibular joint, but today our target is that we should understand the articular disc disorder. First, I will just tell you a very simple thing. You see, this is MRI on my left side, and that is the true cadaver picture. You see, this is, try to understand and try to evaluate the things on radiograph which you are seeing on the real picture. That is the lateral pterygoid muscle inferior fiber, and that is the lateral pterygoid muscle fiber. Here you see, this is the place where the condyle is present. This is MRI, and that is the place which shows the lateral pterygoid muscle inferior fibers. Okay, this is the inferior fibers. That is the lateral pterygoid muscle superior fiber. This is the lateral pterygoid muscle superior fiber with you giving you the film like this. Now, then is the anterior band. This anterior band is here. Exactly, this is the anterior band of the disc. Now, then is the intermediate zone. This is the intermediate zone. This is the intermediate zone of temporomandibular joint disc or articular disc. This is the anterior band. This is the middle band or intermediate, and that is the posterior band. That is the posterior band. Now, this is the discal area at closing. This is the discal area at closing. Anterior limit, middle portion, posterior limit. And this portion is the retrodiscal tissue. Remember this post, as soon as you see the climax of the temporomandibular joint, this climax ends the discal area. Disc is starting from the anterior limit to the posterior limit, but at the maximum height. From the maximum height to the posterior limit, this is retrodiscal tissue. And this has the superior attachment here and inferior attachment right here. This is the inferior attachment which is attached to the neck of the condyle, and that is the superior attachment which is attached to the temporal bone. So that is the anatomy of the articular disc with reference to radiographic interpretation as well. I say that you must evaluate that this is the superior joint space and that is the inferior joint space. Here I come, and this is the inferior joint space, and that is the superior joint space. That you have to understand that what is the radiographic or MRI interpretation of the disc. We will move forward. Now look at this line, that these are the posterior ligaments. They are very soft. They are very soft. They are attached. They are soft, but they are firmly attached. Then the anteriorly there is lateral ligament, and this lateral ligament give also a very good support. When you open the joint, see the superior joint space and the inferior joint space, and in between that is the articular disc. You see the posterior fibers, they are attached firmly, and when you see the disc, this is a flexible fibrocartilage. It has a very soft, like this, fibrocartilage, and it is present beneath the glenoid fossa and superior to the joint. Now look at the movement. They say this is the round movement and this is the sliding movement. When the condyle is right in the fossa, it gives a round movement and disc is placed right there. But when wide opening the bone, it takes the disc with it and then it goes back. Try to understand. That is the movement within the joint. That is the gliding movement. Then when it comes forward, it takes the disc with it. I play again for you, ladies and gentlemen. Look at this. This is just the movement within the condyle. Now we are going to open the mouth, and when you are going to open the mouth, the disc is coming. This is within the joint, and now when you open the mouth, disc will come with us and then it goes back. That is the normal opening and closing of the temporomandibular joint with reference to the disc. Now, this is a very important thing, a very important picture to be noted. Look at this picture on the left side. This is temporalis muscle which is attached to the coronoid process. That is the zygomatic bone going on. And this is the zygomatic process of temporal bone. That is the glenoid fossa posteriorly. I just will explain to you. Now this is the posterior ligaments which are attached to the disc. This is the posterior lamina of the disc, which is generally 3 mm. This is the middle portion of the disc, which is generally 1 mm. This is the anterior portion of the disc, generally 2 mm. That is the superior fibers which are attached to the lateral pterygoid muscle superior end, and that is the muscles of the lateral pterygoid muscle which is attached to the fovea of the temporal mandibular joint head or fovea of the condyle. So this is condyle. This is inferior head of the lateral pterygoid muscle. This is the superior head of the lateral pterygoid muscle. This is disc anterior portion. This is middle portion. This is posterior portion. This whole which I am demarcating is the disc, and these are the posterior laminar point. This is called bilaminar zone, and this whole is the soft tissue. This is the superior giant space, and that is the inferior giant space. Ladies and gentlemen, when the mouth is open, remember one thing. One thing is that condyle do not touch any part of the glenoid fossa. It is always supported by the disc. Secondly, there is always the synovial fluid which become very active and opening of the mouth. It goes from up to down and down to up. And these are the attachments which are present there. While closing, it is entirely a different story. You see, this is the disc. This is the posterior fiber. Remember, this is the climax of the condyle. And when there is climax of the condyle, climax to posterior surfaces all tissue. These are called bilaminar zone tissue. While these climax to forward is the posterior limit of the disc. That is the middle portion, and that is the anterior portion of the disc. This is right there now, and this is the superior head of the lateral pterygoid muscle, and that is the inferior head of the lateral pterygoid muscle. So when the temporomandibular joint is closed, there is no superior joint space, there is no inferior giant space. Every space is being occupied by the condyle, by the tissues of the disc, and by the all the areas which are being soft tissue and connective tissue present here. So there is no space. But when there is opening of the jaw, there is superior giant space, inferior giant space, there is active posterior tissues. So that what I was expecting from you, that you must realize the position of the disc before going to the pathology, and that is the normal anatomy of the disc you must understand. Now we are coming to the normal movement. You see, this is the diagrammatic presentation of anterior to, this is the superior head of the pterygoid muscle, this is inferior, this is the anterior limit of the disc, this is the middle portion of the disc, this is posterior, and these are the bilaminar zone. But look at this, the movement. Movement is this, that the condyle, when it is in the fossa, there is no superior inferior giant space. But as the condyle move forward, there is superior giant space, there is inferior giant space, there is superior lamina, inferior lamina, and when it is closed, that it is closed within the most thinnest part of the disc, which is always occluding, which is always rubbing at the surface of the condyle. This is the main surface which is always in pressure and which is always in there. The posterior disc area, which is 3 mm, and anterior disc, which is 2 mm, is not in so abrasion as the portion which is in between, and that is 1 mm. So when there is condylar movement going on there, remember one thing, the posterior and inferior areas all are being motivated to move forward. And when it is in silent, there is no any space, every tissue is being occupied within the glenoid fossa during the normal movement. Ladies and gentlemen, this is another MRI which you can understand as well. Try to concentrate the things, and try to concentrate the thing in such a way that you can diagnose. You see, this is open, this is superior giant space, inferior giant space, that is disc, and you see that is the lamina going above, that is the going, this is the attachment to the lateral pterygoid muscle, these are the posterior fibers, and this is the condyle of the temporomandibular. Why it is closed? Why it is closed? This is the climax, this posterior portion is the soft tissue, this is an anterior is the disc, and that disc is the placed like this, and this is the fibers to the lateral pterygoid cell, and these are the foveas, inferior head. This is attached to this, and that is the anatomy of the temporomandibular joint at the level of sagittal section of MRI. Now we are coming to the main topic of the clinical, what you say, classification of temporomandibular joint disc displacement. We will study in detail that there are 4 stages. In these 4 stages, temporomandibular joint disc displacement used to occur. And first stage, now please remember the normal opening and closing of the disc. That is very important, because with that reference you are going to understand the pathology. Now in the stage 1, if I say, that is the disc displacement with reduction. What mean reduction? Reduction mean that a disc come back to the joint. Whenever disc come back to the joint, we will say it is reduced, or it is coming to the reduction. So in first stage, there is disc displacement, but with reduction. That means that disc is displaced, no doubt, but it is coming back. It is maybe partial or it may be complete. Now we are going to see it. The clinical sign which we see is clicking and popping sounds during mandibular opening and close, and that is called as reciprocal click. Gentlemen and ladies, now we are discussing the disc displacement with reduction. I have explained the reduction mean that the disc has to come back in the glenoid fossa. That is called as that the disc is reduced. So when there is this first level, that is the clicking and popping sounds during mandibular opening and closing, that is called reciprocal click. That it is there when you open it and it is there when you close it. Deviation of the mandibular midline to the affected early on opening. When you open, it used to deviate on what side? Affected side. You just try to open your mouth and your deflection or your movement of the joint is toward that side which is painful. So first is the target towards painful side. You open the mouth, your mouth will be deflected or your jaw will be deflected on that side where there is problem. Number 1, pain resulting from the sustained discal ligament or condylar pressure against the posterior ligament. So as soon as you touch the posterior portion of the joint, you will get the pain, because it is an initial stage. It is an initial stage. Every lesion initial stage is an inflammatory stage, and inflammatory stages are generally very, very painful. So that is the first stage. And how it happens, you see on this photograph, it is opening and clicking back. When close, it is again, when opening, click back. When it close, it going back again, click. So this is called reciprocal click. Click in opening, click in closing. The giant disc is not coming with the condyle and not going with the condyle. Either it goes forward to the condyle or it goes later to the condyle. it is like this. Now you see the condyle is back and disc is now coming back. When the condyle is back, now the disc come forward. So the disc is not giving its orientation with the movement of the joint. It is coming either faster than the joint movement, either coming later than the joint opening. So this is called the anterior disc displacement with reduction. Reduction is there because it's come to the joint back. Now what you see it on the
disc is until
on
display.
this joint, actually you see this is closed and now the joint is opening. The disc has to come with it, but it goes back. When you close it, this come forward rather than staying there. It come when you open it, it do not come with it, but it goes back. And when you close it, what happened? The disc shift itself forward. So this is the disc displacement with reduction. Though disc is within the joint, disc is following the joint movement, but it is not oriented with the joint movement. It do not stays on the head of the condyle. Either it moves forward or either it moves backward. So what happens that it do not attains the orientation of the temporomandibular joint structure, and it do not obey the laws of the opening and closing of the movement. Next is you see the MRI. No, I am placing MRI again and again because you must have the orientation what is going on radiographically. You see, this is the opening of the mouth. This is the posterior ligaments placed here. This superior joint space, inferior joint space. This is the condyle, and you see the whole the disc that is forward. Rather than placing over it, the disc is right there in the forward position. And when it is closed, what happens? That it is right here. Rather than coming here, its own place, it is coming more forward. And this is the condylar head, and that is the disc, and that is the superior fibers and inferior fibers, and superior joint and inferior joint, and that is what you say that it has changed the orientation. Now, anterior medial disc displacement with reduction. This is another story. Now, disc is there. It is coming anteriorly, it is displaced, but it is more displaced on the medial side. In the first episode, you have seen the disc was just coming anteriorly and posteriorly. But in this second stage, what happens? The disc moves slightly medial. Medial, it is coming, it is coming to the, it is coming to the anterior aspect, but it do not just go anteriorly, it also moves medially. Why medially? Medial side is the attachment of lateral pterygoid muscle. In the second stage, the lateral pterygoid muscle become more spasmed. As we move forward in temporomandibular joint diseases, we will see that the lateral pterygoid muscle become more and more fibrous, more and more tender, and more painful as the disease goes on pressure. So superior head is attached here with the disc, and inferior head is attached here with the neck of the condyle. And when it is there, you see what happens, that it moves medially and anteriorly. Now look at actual what happened. You see the condyle is right here. That is the disc. That is the posterior lamina. That this joint is opening. Concentrate. It is opening. Disc is coming with it. But as it reaches at the climax, what happened? That the disc moves medially. It is gone now medially. No doubt it is anterior, but it has shifted itself to the medial. Now it is coming back. The jaw is closing. Jaw is closing, and now what happening? The disc is again coming back to the lateral side, and it come to the joint. Now, ladies and gentlemen, please concentrate again. Now the joint is opening. The disc is moving anteriorly. But in this case, disc will also move anteriorly as well as medially. You see, now the disc is moving to the medial side. There's a superior joint space, inferior joint space, and now here the you see the disc is gone medially. It is, and now when you are coming back, it comes from the medial side and it is against it. You see, with concentration, now the joint is opening, disc is moving forward anteriorly. There is posterior ligament very loose now, and now this disc is shifted toward the medial side as well. So the disc is not present over the condyle. No, it is on the medial side. But as the condyle move back to its original or closing position, the disc starts coming on the lateral side and it is coming right in the glenoid fossa like this. So there will be also a click sound, but this click sound will be more on the closing as compared to the opening. So that is the second stage. Now there is one more stage, that this stage is very annoying one. At this stage, the whole of the disc is shifted to the medial side. No, the disc is not present on the anterior aspect. It is just when closed, the condyle, whole the disc move inside, and the condyle is abrading the surface of the glenoid fossa. When it come back, it just stay for a while, and again it shifted to the medial side. This is the last stage when there is the medial shift is there and the ligament starts breaking, and at this stage the disc with the passage of time is unable to come back to original side, and with the medial shift is so much that the lateral pterygoid muscle has pushed it so medially that it do not let the disc to retain on the anterior surface. See, the anterior surface is here, and now whole of the disc is gone medially, and this medial surface is engaging the disc. But as you see, when it come back, it just come and again it shifted to back. This is the severe case, is the third degree, where there is very much pain. Patient say that I have a big click when I close the mouth. When the patient closes the mouth, there is a big click, and that is the medial disc displacement with reduction. It is like this. You see, open and it is tuck and it is close again. You see, when she close the mouth, there is tuck sound. You see, there is slight movement, but when she closes it, there is a sound of tuck. You see, that is the disc reduction with sound, and it is the anterior disc displacement with reduction. And the patient will report like this: open and close. Open, disc is forward, medially are. Now the patient closes the mouth, it retain in the gaza, and there is a click sound. Ladies and gentlemen, this is the first stage of the disc displacement with reduction. Now we are coming to the second stage. The second stage is disc displacement without reduction. What mean? That means the disc is not going to have back place in the joint. Disc will not come back in the joint. This may be divided into acute or chronic. First, we have discussed partial and complete. In the partial, what happened that when the disc displacement with reduction was there was coming anteriorly and then coming back. But the complete was there, the whole thing has gone on the medial side. When the stage 2 we are discussing, that is the disc displacement without reduction. That means now the disc is not coming back. It remain anteriorly. It may be acute and it may be chronic. So what are the sign and symptom we will see? Severely restricted opening because disc is placed just in front of the glenoid fossa. When it is just in front of the glenoid fossa, it will not let the joint to open it widely. Then is the deflection of the mandibular midline on opening. There was a deflection that absolutely there is no deviation like this. It is absolutely coming and going back, coming and going back, because there is no disc coming back. It is straight going forward and coming back. Limited protrusive exertion accompanied by the deflection of ipsilateral side. Ipsilateral side, only one side. That is the which is disease. Restriction of the lateral movement to the contralateral side. It is difficult to the contralateral side movement. If you want to do it, it is difficult. Now, what happens actually? No, it is just a dramatic way. This is condyle, this is glenoid fossa, and that's it is the disc displacement. Disc is not in the condylar fossa. And if you see the MRI, this whole disc is placed here. This is all soft tissue, and the disc is forward. It is not coming back. So we see what on cadaver. It is like this. You see the joint, it is coming forward, backward, coming forward. The disc is not coming back to the joint. Disc is not coming back to the joint. Disc will stay in front. This is the superior head of the lateral pterygoid, inferior head of the lateral pterygoid, and you see the disc is not coming back over the surface of the joint. Actually, what happens? It is like this. You see, this is the posterior fibers, and that is the disc. That is the disc. The joint is moving over the posterior ligament or bilaminar zone areas. The disc area is absolutely not involved in opening and closing of the mouth. There will be, due to pressure on the anterior side, there is very limited movement, and here the joint is restricted. Joint is there, but the disc is not coming back. And see the stretch of the posterior ligament. Stretch of the posterior ligament. How much the superior joint space is there? How much? You see how much the superior joint space is there. The joint is absolutely, you see that it looks like that joint is absolutely empty. The whole joint structure is moved forward and it's not coming back. This is the inferior joint space, this is superior joint space, these are the posterior ligament, and this is the anterior placement of the condylar disc. So this is the anterior disc displacement without reduction. Now we are coming to the stage 3, and this stage 3 is disc perforation. The disc perforation is that a joint, due to constant pressure, results into perforation of the discal fibers and discal area. You see, now this is pressure, and the discal portion is abraded and there is a small perforation, and now this is going on in the TMJ. What happened actually? You see, this is the joint, it's opening, and there is disc area. You see, this is disc, and this is the middle portion where there is a disc. There must be a disc, but you see, there is no disc. It is directly with the temporal bone and the condylar head. This whole area is being abraded. This is the posterior portion, this is anterior portion, and you see the whole joint is being abraded. Here there is no any disc there, although look of the disc is there, but when you open it and see on the lateral deflection, try to deflect it and see the what is the condition of the disc. If you open it like this, and you will see that now what is there. It is the perforation right here. You see the disc is there, anterior posterior portion, but there is the perforation. This is the small perforation. This is the posterior disc displacement with posterior disc displacement with small perforation, and that is very painful. And half of the portion of the disc remain posteriorly, half of the portion of the disc remain anteriorly, and in between the joint, where the joint has to move with the disc. Rather than moving on the disc, it is moving over the glenoid surface, and whole the disc surface which has to participate in gliding is being perforated. And when you just open it, and you will see, then when during opening you will see the condyle, and I just tilt it on the lateral side, and you will see this lateral side hole is being perforated. So that is the important. Now, last stage of the TMJ displacement, that is degenerative disease. Degeneration is a very misery, a big misery with reference to temporomandibular joint diseases. You see, now the anterior disc is gone, posterior portion of the disc is detached, and there is absolutely no disc in between the superior, that is the temporal bone, glenoid fossa, and that is the condyle of the head. And this is the anterior portion of the disc detached. This is the posterior portion of the discal tissue, and you see there is no superior joint space or no inferior joint space. It is just going on the head of the condyle with the glenoid fossa surface, and this is a large perforation of the disc is there. There is absolutely grinding of the surface of the condyle with the surface of the glenoid fossa. There is severe painful condition. Here the patient is not able to open the mouth at all. Patient is very painful condition, cannot talk properly, and that is the very last stages of the degenerative diseases of the condyle. If you see MRI, you see here the flattening of the condyle. There is no any disc, there is nothing there, and the whole condyle is being getting the abrasion on the surface of the glenoid fossa, which is normal. If you see that this portion B, it was the normal, but when this was diseased, you see this is a flattening of the joint. Here there was a complete joint, and here when it was diseased, there was the flattening of the joint, and there is no disc, and everything is gone. Ladies and gentlemen, if we see that how to classify the things, this classification of the thing is what is called as the Wilkie's classification or staging. This is very important to understand, especially I would do the general dental surgeon, especially it is very important for them. So this was the normal joint, there was the disc, there was the fibers of the lateral pterygoid muscle, this is the bilaminar zones and posterior capsular attachment. When there is the start, there is a disc displacement, and we used to say that the disc in first stage there is a clicking sound, and the disc used to come back and go with reduction. Here the disc stays there, it is not coming back to the joint, it is staying just in front of that. With the passage of time, there is a breakage, and there is a small perforation of the disc, and there is a perforation right here, that is C. And when we come to the D, there is absolute degenerative changes of the joint, and there is abrasion on the joint surfaces as well as to the condyle surfaces. There is loss of the tissue, there is no disc in between, the condyle, and that is the last stage, which is we used to say at Wilkie's classification degenerative disease. But I will just give you a summary of the Wilkie's staging for the internal derangement of the TMJ. Early stage, early intermediate, intermediate, and intermediate late. You see, actually these are three stages, but we have divided these three stages into five. The intermediate stage, we have divided it into three. That is early intermediate, intermediate, and intermediate late. Early stage and late stage are already there, but intermediate is converted into three. Here you see the internal rearrangement of the early Wilkie stage. What is that? This is the first stage of internal derangement, ladies and gentlemen. Clinical presentation is no pain or decreased range of motion, and there may be very initial stage of clicking. This is initial stage. Radiographically, disc anteriorly positioned, normal bony contour. You will just see that there is slight anterior position of the, it will look like this. Routine, it is like this. But when you see in the first stage, you will see that it is slightly anterior. Anterior displacement, normal anatomical palm of the bone and the disc. This is normal, there is no change. This is a ligament and like this. This is the early stage. Now, early intermediate will stage is what? Here, clinical presentation, patient give the episode of pain, opening click, and intermittent locking. Here, the disc is slightly more drifted forward, and patient feel the clicking sound on opening, and there is slight restriction of the opening of the joint. Radiographically, anterior displacement, thickened posterior surface, you see, thickened posterior surface, and normal bony contour. Bony contour, there is no change. Just in the normal position, you will see it is like this. But when you see the early intermediate stages, posterior thickening, limited opening of the joint, and there is no other bony deformities. Anatomical correlation, you see early disc deformity, anterior displacement, and normal bony contour, which we have seen just posterior thickening of the disc is there. Now, it is like this, which I have shown you previously. This is the early click. You see, the patient is opening, and this is the early click. Here, the patient gets slightly pain on the closing of the mouth. Now, intermediate stage, the pure intermediate stage. These are the many episodes of the pain. In the early stage, there was less pain. But here in the intermediate stage, there is pain, intermittent closing, locking, multiple functional symptoms, and decreased range of motion. Patient has the intermittent closed locking. Patient says, when I open, then it is sometimes it restrict my opening, and when I close, then also it will restrict my opening. So intermittent closing and locking is there. While in case of early stages, it is only just for closing you feel resistance. But in the intermediate, there is a definite, repeated definite, you will see the opening and closing limitation. Then decreased range of motion as well. Patient hardly is easy to open the mouth with ease. Radiographic presentation is anterior disc displacement with disc deformity. Now you will see the disc deformity there, and that is very easily you can see it by means of what you say MRI. That is very easily seen. Anatomical correlation, marked disc displacement and deformity, but the bony contours, they are normal. They have the marked disc displacement. By in case of the early intermediate, there is not marked disc displacement. But in case of the late, there is marked disc displacement and there is normal bony contour. Now it is the intermediate late. Intermediate late clinical presentation are many an increased episode of pain related to early stages. It will be more aggressive, and it is called as the 4 or 5 stage of the Wilkes stages. Here you see the whole disc is placed anteriorly, and this is joint is just moving on the posterior fibers. Disc is not coming within the line of the glenoid fossa, and the disc when closed, this is opening. When closed, there is a whole the disc is placed forward. Bony changes such as flattened adherence, condylar deformity, and osteoclastic changes, it started here. It started here. You see, this is not round absolutely. There is slight changes on the surface. It started with the passage of time. Anatomical correlation, adhesion of the disc is adhered to anterior limit. There is bony changes, evidence of osteoarthritis, osteophytes, and no disc perforation. Disc is just gone anteriorly. In toto, this whole disc is placed anteriorly. There is perforation. There is you see a disc perforation is not there, but the ligament perforation is there. Ligament is posterior. This is anteriorly, and this is the deformity of the bone. Here you can see the osteophytes. You see, this is a simple elevation which look like this is a osteophyte. So that is the intermediate late, and it is like this. You see, it is just a condyle is there, and it is rearrangement. It is placed anteriorly, absolutely not coming. And what happens to the patient? You see, the patient has this whole deviation. There is absolute deviation towards the affected side. The absolute deviation towards the affected side, and patient has no movement coming back. Last stage Wilkes is a very important stage. The last stage is when clinical presentation is the continuous severe pain. Patient is not even just relaxing, even cannot talk. Very limited range of opening. There is a difficult functioning, even eating and taking food is difficult for him. You see, this is the experience. You can look at this. This is the condyle, and this is the disc. All the disc being perforated. Radiographic presentation, disc perforation, gross deformity of the bone structure and cartilage, progressive arthritis changes. Anatomical correlation, you will see gross, hard, and soft tissue changes, perforation, adhesion, and sometimes there is cervical cystic appearances also. This, so the whole the joint structure is gone, joint is demodulated, the disc is perforated, disc attachment is gone, the structure of the condylar head is gone, the glenoid fossa surfaces are also abraded. So the in the late stages, absolutely every type of joint placement or joint stay is gone. So that is the stage 5. You see that this is the joint. This is absolutely, there is no structure of the joint. You see that this is joint surface. This is the soft tissue area opening and closing, and you see there is absolutely no any condylar structure present there. Now, in summary, early stage, no significant mechanical symptoms other than early opening and reciprocal clicking, no pain or limitation of the movement. Clinically, radiographically, slight forward displacement of the disc, good anatomical contour of the disc, negative tomograph यानी MRI पे आपको कोई चीज नहीं मिलेगी, you can see nothing in MRI. Anatomical, pathological, axial and anatomical form, slight anterior displacement of this disc is there, and passive incorporation of demonstrator is absolutely, you will see the normal. But in early is early intermediate, one or more episodes of pain. Now here started the pain. In the first stage there was no pain. Big a major mechanical problem consisting of mild to late opening, loud clicking, transient catching, and locking. Then here it starts. Radiographic, slight forward displacement, beginning of the disc deformity or slight thickening of the posterior edges, and negative tomograph. Yet tomograph is negative. Anatomical and pathological anterior disc displacement is there. Early anatomical disformity is formed, but the articulating area is yet promising. In the intermediate, exact intermediate, multiple episodes of the pain. Major mechanical symptom consist of locking, intermittent and fully closed, restriction of the motion, and difficulty with the function. Here it starts with the difficulties of the function. Mastication become difficult, and talking is slightly difficult. Radiographically, anterior disc displacement with a significant deformity, prolapse of the disc increases the thickening of the posterior line, as we have described in posterior, and negative tomogram, yet the tomogram shows no changes on the glandar fossa. And anatomical pathogenic, marked anatomical disc disformity with the anterior displacement of the heart tissue changes. When we come to the intermediate late stage, increase in severity over the intermediate stage, positive tomograph showing early to moderate degenerative changes, flattening of the eminence, and deform the condylar head sclerosis. What about the anatomical and pathological? It is increased the severity over the intermediate stage. Hard tissue degenerative remodeling of the both bearing surfaces. Osteophytes are there, multiple adhesion are there, anterior and posterior recess, and no perforation of the disc because this is just placed anteriorly, just the fibers are gone. In the last stage, which we have described, the absolute clinical crepitus, scraping, grinding symptoms, episodic, continuous pain, chronic restriction of the motion, difficulty with the function, all the joint functions, they are gone. Disc attachment, perforation, filling defect, gross anatomical deformity of the disc and the heart tissue, positive tomogram with the excessive degenerative arthritis changes. And when you see anatomical or pathological, there is a gross degenerative changes of the disc and heart tissue, perforation of the posterior attachment, multiple adhesion, osteophytes are there, and flattening of the condylar and its eminent subcondylar cystic area also visualized. Ladies and gentlemen, these are the basically degenerative diseases of the disc and their how you can evaluate it clinically, radiographically, MRI. Ladies and gentlemen, we are going to cover this whole TMJ season. We have covered season 1 with reference to anatomy, and this season 1 of the anatomy contains 3 episodes, and we have covered this season 1 of the temporomandibular joint anatomy. We are in this 3 episode, we cover the whole of the embryology, Then we have covered whole of the development of temporomandibular joint in every aspect, right from the intrauterine to the adult. And then the second episode was the histopathology and the chemical compositions of the fluids and all the histopathological orientations and all details of the phagocytosis and the function. Third was regarding to the function of the whole the disc, and then function of the canine fossa, condyle. Then we have studied the muscle of mastication in detail, and we have gone for the every movement of the temporomandibular joint, all the movements, eight movement of the temporomandibular joint we have seen with reference to the condyle, with reference to the joint, with reference to the centric occlusion, with reference to the adopted occlusion, with reference to the interdigitation, bruxism. All these we studied in that season one. In season two, we have the diseases of temporomandibular joint, which we have two episodes. In first episode, we have covered this was the introduction to the temporomandibular joint diseases, and this is second which we have covered today, that was the diseases related to disc. And third will be the temporomandibular joint diseases, that is can I see can
Yes, yes, you can.
uh, in the third episode, we are going to cover the neuromuscular phenomenon related to temporomandibular joint and its diseases. So this will cover whole of the diseases of the temporomandibular joint. And lastly, then there will be two season more. The next season will be of the diagnosis, and will cover the investigation, it will cover the examination, it will cover the history taking and all these things, which will be the season 3. And the season 4 will be our very comprehensive season, and that will be covering the treatment of temporomandibular joint. We will start temporomandibular joint diseases in season 4, right from the medication to the supplement therapy, to the exercises, to the surgery, to the orthography, orthocentosis, then we will open joint surgery, then treatment of the ankylosis, fibrous ankylosis. All these season, and this fourth season is for the treatment of temporal mandibular joint. Ladies and gentlemen, these 4 seasons of the temporomandibular joint basically cover 40 lectures. And these 40 lectures, we will try to cover the maximum of the temporomandibular joint. Now, today's session, we have covered the disc-related diseases, their clinical, their radiographic, and their interpretation with reference to diagnosis of the stages of the disc deformities. Now I'm here to answer your question. It is over to Dasab. This is a very great actually contribution by the Association of International Dentistry Pakistan. Really, I'm very proud of Association of International Dentistry Pakistan, because there's no person or no association who is working on such level that they are giving the feed of knowledge. There's generally webinar going on always. They're just showing the clinical cases, or just showing their output, and which is generally just for the good for the knowledge, clinical knowledge. But the basic are giving the training and getting the basic orientation with reference to their fundamentals. It is generally missing. So these season, no doubt they are going to cover all the clinical aspect of the temporomandibular joint as well. But we have given the complete know-how is to Z of the temporomandibular joint. Now I'm here to answer your question. If you have any question, I'm here to answer.
If somebody has any questions, you can ask questions in chat box and through Facebook
Yes,
comment.
please.
Sir, a question from our fellow. Kindly explain disc position in normal opening and closing of the jaw.
Rehan, Dr.
Yes, sir.
Rehan,
Yes, sir, I am
are
here.
you with me?
Yes.
Dr. Rehan.
Yes, I am here with you.
Yes, Dr. Rehan.
Yes, sir, I am here.
Yes, sir, I am here.
जी सर, वो सर मेरे ना थोड़ा सा इधर माइक का इशू है।
अच्छा, कोई बात नहीं। मैंने कहा कि क्वेश्चन मुझे बता दे ताकि मैं उसका कोई जवाब दे दूं। किसी का कोई क्वेश्चन है तो बता दो।
ठीक सर, मैं आपको बता देता हूँ। Can everyone hear me? Can everyone hear me?
Please write down your question in the box or raise your hand if you want to directly.
So there is a question.
There is a question.
Dr. Sharad, can you hear me?
Can you hear me?
Kindly explain disc position in normal opening and closing of jaw. Dr. Arshad?
Maybe he is
If
having some network.
any person like to ask a question directly, we can raise hand and directly ask me the question.
Sir, can you hear me?
I received one question from the Imam that explain the image of disc on MRI. It is very easy if because the sharing of the in the next lecture actually it is very much with reference to MRI as well, because I am going to explain next time the muscular problems and the muscular problems to the temporomandibular joint. It is very easy that the best images we get the disc or the joint is by MRI. And it is very easy to understand. Just if you get the orientation of the temporomandibular giant, one picture you take the MRI and second picture you take the cadaver, and you just negotiate with these two images, you will come to know the exact what you say anatomy of the uh, mm, temporomandibular giant. Is no uh, problem. I have actually explained, you maybe not, you have joined later, that I have described in detail the MRI disc position in opening and in closing. Even I have described it in a functional way as well, that functional MRI is there, and we have explained it.
Okay, all of the participants, thank you so much for attending the lecture, and especially
Yes, there
Dr.
is any
Arthur.
question? जी बेटे, आपका कोई फेसबुक पे या कहीं पे क्वेश्चन है पूछे? Yes, it is always that you have the best choice of MRI for the disc perforation, disc anterior disc displacement, medial disc displacement. MRI is the choice. People used to go for the arthroscopy as well, but to see the disc perforation. But I think that the MRI is the best, what you say, device for giving the result. Because the disc has to come back. Disc has to come back. When you are closing the mouth, disc has to come back. And when the disc try to come back, what happened that the posterior ligament tried to take it on its original position, and resulted it that the condyle has to grind the surface of the disc. So that's why there is click sound on closing. No, no. I say that if there is any disc disorder, then there is no second option. I think that MRI is the best, because without MRI, you cannot say that whether there is a disc perforation, whether there is a anterior disc displacement, medial disc displacement, it is a perforated or not perforated. These are parameters you cannot see it clinically. You can just see it click sound, and you will just see pain or not. There are many dental surgeons I see here. They are general practitioners. They are right here. If they want to ask something, they can ask. So many general practitioners. They face the routine. Nicole Avachong, I see that he's a very good, mashallah, and Sunny Shuharili is there, and he's also a very good listener.
All of the participants, thank you so much for attending the lecture, and especially Dr. Arshad Malik, who delivered this amazing lecture. If anyone wants to get certificate, there will be a quiz after the last session. If someone will score 70% or more, they will get the certificate, and these certificates will be accepted by Association of International Dentistry and International College of Dentistry. You will be updated through our Facebook page, facebook.com/aid.dentistry, and our website, www.aidofficial.com. So kindly stay tuned with our page and YouTube channel. And this lecture will be available at YouTube channel. Whoever missed any part of this lecture, you can see there. Please like, follow our Facebook page, and please subscribe our YouTube channel. Thank you.
Thank you, everyone, and inshallah, we are going to have our season 2 last lecture, and then we will start our season 3, that is for the diagnosing the TMJ lesions. Thank you very much. Till next day. Thank you.
Make sure to like and follow our Facebook page so that you can be updated lively. If you have not registered yet, you can register for session 3rd of this same series. You will be able to get your certificate if you will be registered only. Otherwise, you will not able to get any certificate of the whole session. Thank you so much, everyone. And if still anyone have any question, someone raises hand, you can ask in Facebook comments. In the next session, you will be answered. And if any other query, you can WhatsApp us or Facebook comment anything or inbox, we will answer there.